I'm glad we got to meditate before this because I'm going to cover a lot of content, so you guys need to be very focused on the information here. So basically, I retitled this talk to be a storyteller's approach to healing patients because I went through the traditional medical system and I realized that the real way that I've been able to connect with my patients is by telling stories that really resonate with them. So I want to take you through my journey and how I've used that journey to really engage many of my patients. You got my background already, but one thing I wanted to add is right now in my clinic, the thing I'm most passionate about, so my daytime job is I go out to high-tech companies to design health education and wellness programs. And the patients that actually give me the most, gratitude are the ones that are the most difficult to engage. So the ones that have just come from India, China, or a different country where they don't understand how to eat, where they've never actually done any form of exercise. These are the ones actually the companies care about the most because that's the 5 or 10% that's actually driving up the healthcare costs for the entire company. So they look to me to find the solutions of how do you really engage the most difficult to engage patients. So I want to take you through some of those stories behind that. So I call this my 3-step storybook approach. The first thing is really, what is the patient's story? I learned about history taking in medical training, which is more of sort of a concrete, sort of a subjective process, but this is really more learning about their story. I focus a lot of time on understanding what their culture is, what is their relationship to food and exercise, what are family traditions? Family traditions are really important because many of my patients have come here, they've completely disconnected from their family traditions. So when we talk about what mom used to do, or grandmother and aunt, all of a sudden I can actually find an avenue to help them reconnect with that tradition. The second thing, which has been really key, and I think this is the reason why I've had a lot of success in Silicon Valley, is explaining what the scientific story of what's happening in their body and using the right language. Some are more Western aligned, some are more Eastern aligned, but how do I tell that story in a way so people understand what's happening in their body? And what I would tell you as practitioners is if patients don't understand exactly what's happening in their body, they're not going to follow your dietary advice. So I'm going to spend some time telling you what stories have been most effective. And then finally, how do you find a lifestyle plan that aligns with those? The rickshaw story is one I came up with because after people came across my work, and especially because I'm focused on reversing diabetes and heart disease risk, I often found that I had to cut back on a lot of refined carbohydrates and the beloved rice and noodles that my patients like to eat. So when they typically come back to me and say, why can't I eat the foods that my family, my village, my ancestors ate, I give them this analogy right here. I'm from a part of India called Calcutta, and when I grew up going to Calcutta, I was obsessed with rickshaw pullers. I loved watching rickshaw pullers all the time. So I give the analogy here of comparing a rickshaw puller to a sedentary high-tech software engineer. Okay, and so let's say that this person wants to eat rice, and this is the kind of conversation I have, is a rickshaw puller, and I actually dug this up somewhere, runs about 40,000 steps a day. My average techies walk about 2,000 steps per day, and I actually track their walking steps like a vital sign. Strong leg and core. These rickshaw pullers have a tough job because Indians are becoming heavier with every year. So they have to pull along heavier carts of wood. So they have to have a very strong leg and core to do that. And we know our sedentary office workers have a very weak leg and core just from sitting at the computer all day. Normal vitamin D levels, they're out in the sun all day, some minimal, they have more exposure to skin to sunlight, so they usually have absolutely optimal vitamin D levels, but we see an epidemic of severe vitamin D deficiency in our population because we're bathed by screen light instead of sunlight. And then for somebody in that particular metabolic state, eating lots of rice and carbohydrates is fine. They thrive on that because their muscles need that energy. But for this individual, if we exceed that amount of carbohydrates, we see metabolic disturbances, diabetes, fatty liver, all the issues that we face in the clinic. This is the insulin resistance traffic story that I use to teach doctors, patients, what's happening inside the body. So this is an image from my book. And I tell them this is really what insulin resistance is. You've got this car in the middle. Let's call that, the carbohydrate car. We have 3 parking lots in our body, the muscle, liver, and fat. The ideal destination for that car is to go to the muscle parking lot so the muscle can burn that for energy. And the insulin is basically the parking pass that will get the carbs into the muscle parking lot. So when I tell people that they've become insulin resistant, what I'm telling them is their body is producing the parking pass, but the muscle has decided not to respond. So maybe some of the carbs get inside the muscle, but then we have this overflow traffic, and that overflow traffic is distributed to different lots depending on each individual. I see a lot of couples in my clinic, and not to stereotype, but this is a common trend I see, is I'll have a slender Asian or an Indian male and maybe a spouse that's a little bit heavier. And they're like, why is this happening? And I tell them, well, in his case, he may not be distributing contributing carbs to fat as much is going to the liver. So that's why he's got the higher cholesterol, the fatty liver, the high triglycerides. Whereas in the spouse's case, we might be having more of the carbohydrate card going towards fat storage and less to the liver. But once they understand this paradigm, then as I give them lifestyle recommendations, it makes a lot more sense. This is another thing I really spend a lot of time explaining is the skinny fat story, because in Asians, East Asians, and Indians, we develop heart disease and diabetes as a much lower body weight. So I typically tell them that when you think about body fat, think of a jelly donut, okay? There's two compartments. The subcutaneous fat is the covering, the crust of the donut. The jelly is the inflammatory, dangerous fat, okay? And the subcutaneous fat is contributing more to our body weight, right? The inflammatory fat in the middle is not as visible. If you look at the distribution of jelly to crust in different ethnic groups, you'll see that Caucasians, they have a moderate amount of jelly, kind of a balanced amount of subcutaneous fat. African Americans, interestingly, have less jelly and more of the subcutaneous fat. So a lot of their heart disease is coming from hypertensive heart disease rather than diabetic heart disease. Look at the Asian paradigm here. So Asians have a lot of jelly, right, more of the hidden fat, but a very thin crust of the actual subcutaneous fat. And that's why many of my patients that are high risk are normal or under body mass index. And this is an interesting diagram of two famous obesity researchers in The Lancet, and this shows this clearly. They both have identical body mass indexes. They're at an Indian wedding. You can see the saris in the back there. But if you look at their body fat using a DEXA scan, the dark purple is body fat. So the skinny Indian guy on the right, the one whose mom wants to constantly feed him and get him to gain weight, his body fat is actually 21%, whereas the guy on the left is 9%. So this is where body weight and body mass index can often be very incorrect, especially in patients of East Asian, South Asian background. So then I tell people that, I don't want my engineer to quit his job and start pulling rickshaws down the 101, but we can use some ways to sort of bridge them to their past. And the interesting thing is if we can take some steps and move them slightly in that direction, we can see significant improvements in their health. Now, Erica appropriately brought up the story of the epigenetic story, and this is something that's really important because many of my patients come from families where every family member has become diabetic. And they have this sense of genetic determinism where they feel like, well, I might as well enjoy life because I'm going to be diabetic at 52, okay? And really, I see this pattern so much, but then I kind of explain in lectures that think of your genetic material as being sort of a cell phone, and yes, you've downloaded different apps maybe from your family members, maybe an app for type 2 diabetes, for obesity, heart disease, Alzheimer's, etc. But the thing is, we can, in most cases, control whether those apps get turned on or off. Perhaps it's the food you're eating. You didn't necessarily inherit the gene for diabetes, you did inherit that, but the eating pattern, your family's been eating the same pattern for many generations, and that worked when your ancestors were physically active, but here in Silicon Valley, that's not working for, we need to modify that. Could it be micronutrient deficiencies, inactivity, stress and sleep deprivation, toxin exposures? These are all things that can turn apps on and off. And the empowering thing is when we can get people to really find what those inputs are, and we see that their numbers are not getting worse, their glucose or lipids, they can become the one person in the family that did not develop diabetes or heart disease risk. So really having time to explain that can really give them a sense of freedom and hope that they can really reverse a lot of chronic health conditions. So in medical training, there's a term we use, IVDA. It usually stands for IV drug abuse, but actually is an acronym for Indian vegetarian diet abuse, because many of my Indian vegetarians feel like because they're vegetarian, they're bulletproof. They're not going to develop these conditions, but their iteration of the vegetarian diet, especially here in modern times, unfortunately has become very unhealthy. So I kind of joke that that's the vegetarian typical Indian plate. So it's a carb bomb. You've got flatbreads, those brown golf balls are Indian sweets. Vegetables actually serve more of a decorative purpose. So we put the two tomatoes and the cucumbers in the corner. Many times that does not get eaten. Basically it's just left on the plate and then we eat all these foods. So obviously looking at how people, so if they say vegetarian, we really have to dig down and see, are they truly eating vegetables, or is it coming from a lot of these types of carbohydrates that can raise inflammation and make our carbohydrate trapping problem worse? Okay, so food trackers are a big part of my practice. I get people to download some sort of food tracker. And interestingly, a lot of people are using these sorts of apps already, but they're not focused on the right numbers. They might be looking at calories, they might be obsessed with fat because dad had heart disease, but we actually have to teach people what numbers to really focus on when they use these food trackers. Common patterns, which I don't think will be surprising to you, are excessive amounts of sugar and carbohydrate intake. So I sit down and set specific goals depending on people's activity patterns or metabolism. I see lots of inadequate protein intake. Even in our modern iteration of diets, people that are doing a lot of low-carb ketogenic style diets, I see that they're taking in insufficient amounts of protein, and this is really having an impact on their metabolism, their energy. So really making sure that we're keeping track of what the target protein is really important, and then going over healthy fats, which are often lacking, and some of our speakers have talked about that already, and really assessing whether they're getting sufficient plants in their vegetarian diet. The targeting here is really critical, and a lot of you might be familiar with this, but if I can set a number, I basically will have them go through a 1-week exercise of tracking how many grams of carbohydrates they're taking in. And for a typical Asian, it is 400 to 500 plus. I have patients taking in 700 to 800 grams of carb per day. And they don't realize it, until they quantify, they're like, no, I think I'm within this range, but until they quantify, they don't know. And yes, it might be tough initially to get them down to 100 or 150, but even if I can get them down by 25, 30%, we can start to see body fat going down, triglycerides dropping, and numbers improving, and then all of a sudden they're engaged and they're willing to do more. So this is an example. I give a lot of my patients that I see, typical Indian meal might be 1 flatbread, one or 2 flatbreads, cooked lentils, maybe a potato-based curry. So I often will highlight the fact that this is enough carbohydrates basically to really drive triglyceride production in somebody who's not exercising. This is one typical meal. So once we can diversify these foods and add the healthy proteins and fats, we can actually retain the caloric consumption, the satiety, while we're not really driving up the carbohydrates to excess levels. So I call these carb copycats. So back when I wrote the book about 5 or 6 years ago, I was teaching people how to make these carb copycats so they can eat vegetables naturally. Many of my Indian Asian patients will never eat salads. They've been clear with me that they're not going to touch salad, but how can I actually turn their rice into, how can I turn their rice into a vegetable? And I had recipes for that, but now if you go to any grocery store, they've got pre-riced cauliflower already. So that's just so convenient now, but teaching them to do this is great. I tell them that instead of eating plain white rice, eat it like an Asian fried rice or eat it like a biryani. Reduce the amount of rice, but add vegetables, proteins, and fats to that, because that's going to dampen the glycemic spike, it's going to lower inflammation, and you're magically actually getting them to eat vegetables without having to eat salad. So these are some of the tricks that have really helped patients do really, really well without having to put in much effort. Now, saturated fat we talked about, right? Butter's okay for everyone. Not necessarily. For most of my patients, they do fine, but I do tell them that there are some genes, and we're starting to identify this. I'm working with a company where we're looking at some genetic markers. These are some genes, because I've noticed in some patients, they're very saturated fat sensitive. They go ketogenic, they start eating butter, their cholesterol goes through the roof. And here's an example right here. This is a patient, you can look at their LDL, and back in June 2016, an LDL of 684. This is typically a patient you would refer to Stanford or UCSF for lipid management. You do genetic testing to see if they have a condition called FH. But with him, what we did was he was on a high-fat ketogenic diet. We gradually transitioned to 0% sat fat. We replaced it with mostly monounsaturated fats. We added avocado, olive oils, all these things. And look, without medications, we went from 684 to 113 in October 2017. Without meds, we completely normalized him. I didn't do genetic testing, but he's one of these people that is saturated fat sensitive. A high sat fat ketogenic diet won't work. We need to diversify fats. So you can see these sorts of personalized trends. And I think the modern movement with genetic testing makes this very exciting. Now, resistance training. I was in India one summer during the monsoon season, and I was trying to get to my uncle's wedding, and this guy was basically pulling me through flood rain situation. I'm like, this is the ultimate form of resistance training. So, I tell people, so coming back to our story, many of my patients are very resistant to lifting weights. So again, I come back to this. I tell them that if we can get your muscles, especially your leg muscles, stronger, that's more carbohydrate storage space. We're trying to increase your parking lot space, because guess what? If you have more parking space, you can have an extra bread, or you can have some extra rice, basically. So how do we change your body composition so you can pull in more space? So that's a little bit more engaging than telling them, sign up for this gym and start doing, burpees and lunges and all this stuff. So this is basically what we do. And we align it to the fact that, hey, a lot of the exercises that people are paying a lot of money to trainers for are things that we've been doing in Asia for many, many years, right? So when you load somebody into a rickshaw, that really is like doing a dumbbell or a bar lift, right? Sumo squats are basically basically, this guy does it better than any physical trainer that I've seen. And then farmer walks, suitcase carries. These are all amazing exercises you can integrate that really have an ancestral tradition. So really giving this sort of imagery gets people to do these sorts of exercises. And these are functional exercises. There's a lot of fancy things that trainers will have you do, but I want to be able to carry my suitcases when I'm 80 years old. I want to be able to load things into the higher shelves. So these are more functional exercises that you want to motivate people to be able to do. Now, interval training, stop and go exercises. Rickshaw pullers aren't running continuously, they stop and go. So I tell them that if you can incorporate some sort of exercise where you stop and go, it could be Tabata, you can use a Seconds app to do this, but they've even shown in people that can't run, in elderly patients that just walk fast, walk slow, walk fast, walk slow, the impact on glycemic control, glucose control is much more profound than walking in a steady state. So any form of interval training is useful for patients of all ages. And these are some additional circuit training apps that I've recommended and prescribed to patients. Okay, so I tell people, the rickshaw puller isn't basically getting exercise to improve his body composition, to improve energy. He does it because that's his job. And for really most of my patients, I need to teach them how can they be physically active while they work, at least during some part of their day. So that's me on my elliptical. Those are my identical twin boys right there. And I wrote 80% of my book on an elliptical trainer with a laptop. When I write blog posts for my blog, it's mostly on some sort of active workstation. So this is a new generation of work. We have to find how we can get people out of their chairs and do some sort of active walking. So there, I actually do that in the middle, like an Asian squat. So I've got a low stool. I'll often do that when I'm on my laptop and I'm actually typing. We want to retain hip mobility. But now the new modern workspace is incorporating a lot of these elements. So I think it's an exciting time that we're evolving out of our typical chairs. Activity training, we're all familiar with these devices. The key thing I tell my patients is make sure you've got about 4,000 to 5,000 steps by 1 p.m. A lot of people try to get all their steps done in the morning or the evening. They sit all day. The newer generation of trackers do check your hourly steps, but I tell them by midday we should be getting at least half of our steps in there. Now, there's a lot of numbers on this, but one of the things I struggle with is how do I get my patients to meditate and do mindfulness practices? And in my practice, it's a bit of I call it a bitter tragedy because 80% of my patients are Indian, and when I ask them if they meditate, the vast majority are not meditating at all. Okay, so we basically have to make sure that we can motivate them in some way. So I'm going to quickly just show you this slide. This number right here is a C-reactive protein. It's a marker for inflammation. His number was very high at 10.6. We made some metabolic changes that dropped him down to 3.6, but we got him to 0.6, completely normal C-reactive protein, just through meditation. So that was a direct scientific connection for him, that mindfulness breathing lowered his inflammatory marker. So giving this sort of scientific evidence can often be very empowering. I want to just end with the fact that, there are great tracking tools. If you have patients that are not going to meditate no matter what, I often do have them check their resting pulse. If they know what their pulse is while they work, while they drive, we can incorporate some breathing exercises to help them. So HRV is another technology that's really useful. HRV is heart rate variability. It's another version of the pulse that can really help you regulate your sympathetic nervous system. I blog a lot about how to use HRV. And one quick tip I want to tell, almost everyone in this room is probably wearing some sort of heart rate type device. On the Apple Watch, one of the tricks I teach them is you go into your watch app and you set the breathing rate for 4 breaths per minute. And throughout the day, you drive, you work, whatever, see where your heart rate is. And that's been a game changer. I call it active meditation. Meditation is basically trying to lower your heart rate during physical activity or mental activity throughout the day. That can be a powerful way for them to really regulate stress. These are additional meditation apps that I've prescribed to my patients. And then really the overall goal is if we can do a lot of these things, adequate sleep, control stress, moderate the diets, we can start getting the carbohydrate car moving back towards muscle. That is our overall goal. Okay? So this is my story. These are the numbers I show almost all of my patients of how I had metabolic syndrome and how I reversed it, how I did my own dietary tracking. A lot of the healers that I've met have had their own personal struggles, and I've learned to become more open about that, and this really helps me connect my story to my patient's story. And then finally, last slide here is team-based care. This is really what we need to help our patients and support them. We might have colleagues that we refer to, community practitioners. The nice thing is, because I work with companies like Apple and Google, I know what are their personal trainers. If they need a resource at work, I can engage them and actually utilize that resource out there. And then multimedia. I mean, there are people out there that you can use, YouTube videos or websites, etc., to engage people, and then you can monitor the results as they make these lifestyle changes. So I'll race through that. These are my resources. I blog and write actively here. You're probably going to need a meditation session after this talk because I cover this pretty quickly. But I'll leave it right there, okay? Thank you very much for having me. All right.
Okay, so this is Dr. Yangdron's case, just to explain. So Dr. Yangdron and I met at a family medicine, which is my department, dinner. And that's how we got involved. And since then, we've shared several patients. I've referred to her, she's referred to me, back and forth. And this patient is not a patient that I have seen, but after Dr. Yangdron prepared the case, then she showed it to me, and then we got to interview the patient by phone. So I'm going to present sort of the Western side of this case, and then she'll bring in the Tibetan side. Okay, so this is a 28-year-old woman with PCOS, which is polycystic ovary syndrome, presenting with several menstrual symptoms, and she's also having multiple emotional and somatic symptoms, and somatic means body symptoms, so lots of symptoms in her body of various sorts. And we're going to go through kind of a SOAP note format, which is a type of note that we use in medicine, and that contains the subjective, which is how the patient describes their own concerns, history of present illness, their symptoms, and their goals. Then we're going to go over an objective, which is how we examine the patient and any studies that we may have done. And then assessment, what do we think the problem might be? What is the differential diagnosis, which is what other diagnoses might this be, if not the one that we have in mind? And then plan, what are the steps in further evaluation, and what are we thinking in terms of treatment? And so in subjective, this patient came in with depression and anxiety. She was tired, had low energy, mentally foggy, hard time thinking. Her vision was blurry. She had migraines and persistent headaches. She had overactive bladder and severe PMS with worsening migraines, nausea, vomiting, extreme pain with her periods, menstrual cramping throughout the period itself. She had about 2 weeks of time that she was unable to get out of bed from the week before her period through the week of her period. She had worsening anxiety and depression, actually all occurring since the death of her father, which had happened, a year beforehand, and menstrual periods irregular since the age of 12. She was diagnosed with polycystic ovary syndrome at the age of 17, and then cysts had been detected in her kidneys and her liver, although she had not been given a formal diagnosis of something that we call polycystic kidney disease, which can also affect the liver. And she does understand herself from her medical team that her ovarian, kidney, and liver cysts are all related. But she has not undergone or been offered any genetic testing. In her family, her father had polycystic liver and kidney disease that was formally diagnosed, and he died of that condition. His sister and great aunt had the same, and both passed away from that condition, and they both had related diabetes and kidney failure. And his mother, her father's mother, had polycystic kidney and liver disease as well, but she did not have associated diabetes, and she's still alive. On her mother's side, her mother had the polycystic ovary disease, but no family history of diabetes. And there was no family history of breast or ovarian cancer, and no other significant family medical history that she knew about. And again, she had not been offered any genetic tests. She was also not aware of any family members, including the ones with the known polycystic ovary and kidney disease, having been offered any genetic testing, and in some cases just not available at that time or for that condition. She is taking, at the time of Dr. Yangdron's visit, vitamin B12 and an oral contraceptive tablet, which, if any medical people are on here, is a monophasic, estradiol and norgestimate, 0.035 and 0.25 milligrams of the progesterone component. Social history, she's single. She maintains a living as a caregiver for her grandmother. And then, again, I haven't done an exam, but I just went through the components that would be in an exam. So we would take vital signs, look at her general appearance. We would take a look at her heart, lung, head, eyes, ears, nose, and throat, abdomen. The pelvic exam would be very important in this patient. So we'd check internally the uterus, the ovaries, and do a full neurologic exam, given all of the headaches and everything, extremity and vascular exam. We would probably do a depression and anxiety at least assessment. There's a short form called a PHQ-9, probably at least be done in the clinic setting. And then we would take a look at any studies, x-rays, and labs that had been done for her. So in assessment, a 28-year-old woman with polycystic ovary syndrome, as well as probable polycystic kidney and liver disease based on family history, who suffers from complicated grief with persistent anxiety and depression, who's at high risk for diabetes based on her family history and PCOS, and at risk for kidney failure if the polycystic kidney and liver disease is confirmed. So our plan would be we would want to rule in or out that polycystic kidney and liver disease through imaging and probably a genetics referral to see if testing could be available for her. We would probably evaluate her adrenal function because some of the symptoms that she has sound like they could be symptoms of adrenal failure where our adrenal gland's not secreting the right hormones. Psychiatric assessment, a formal psychiatric assessment, be very important, and possibly a cognitive behavioral therapy referral, mindfulness, mindfulness-based stress reduction or meditation training if available. And then proactive preventative management would probably be the most important thing, which would be weight management, nutrition counseling, a sleep study and behavioral sleep therapy, avoidance of substances. If we're thinking about the kidney and livers, we want to make sure she understands what's toxic to the liver, alcohol, Tylenol, and what's toxic to the kidneys, which is especially NSAIDs and other things, and just make sure she knows to be very careful with those types of things. And then exercise recommendations and support. So that's just another summary of the same sort of thing. And this is more sort of the diagnosis codes. But I'm going to switch over, because I think we're a little short on time, to Yangdron.
So I will keep it short because I don't need to repeat all the history. So what I'm going to start from the diagnosis. So since we have a standardized SOAP note in Western medicine, I came back with the Tibetan traditional medicine method of diagnostic. We go direct to 3 steps, which is observation, palpation, and questioning and inquiring. So I made into OPQ version. And with this, so this is a procedure like the differences is in the Western medicine, you have patients to tell you what their feelings as a subjective, but in Tibetan medicine, what we do is as an observation. So at the moment the patient steps into your room or your office, so you're using your eyes, you're using your ears, you're listening, you're watching and see what is the patient doing in terms of how they move, how they talk, including their talking is a part of thing that you're going to put into the assessment. And observation, what do you need to observe? Overall in general, but also you saw I was doing the eyelids. I always found very useful to find out anemic symptoms, including the eyelids, nails, and tongue, and gums. All these 4 things are my 4 signs, like quickly look less than 30 seconds. I can't tell you the exact number, but the patient, if they're going through the, the anemic symptoms, so they're always indication. Then in terms of observation, there's 2 other important parts is the tongue and urine. So tongue, color, thickness, all those are part of them. And urine, again, urine is not done by the technician. You send to the lab. As a Tibetan medicine doctor, trained Tibetan doctor, you are able to, or you must be able to perform the urine analysis in a clinic setting. So you have to use that as your diagnostic method. And then palpation. So we're using this morning Dr. Ron had that arm. Do you remember that hand on the bottom? So actually he pinpointed on the wrist pulse, wrist artery. So basically what we check is the raised artery. There's a two-one. This is a general pulse checking area where the raised pulse, and there's another one is the ulnar side of the pulse, the artery. It's called the Latza. So there's a two ways, but mostly it's done by the first one on the raised side. And palpation. Okay, another thing about the palpation is if someone comes, describes to you, I have a bloating sensation. So I wouldn't just say, where is the bloating, but I would feel it, because the moment when patient tells me, when they tell me, I listen, right? After I listen, once I either have them lie down on the table, or once I touch my hand on their body, you really can learn about the patient. Then I start to palpate their abdominal, their head, their feet, their body. Along with it, then you can tell what type of discomfort or they're going through, but at least give me some information. And then the last one is, but not the least, and the most important thing is the questioning and inquiring. So we normally say kanki, kana, kantu, kan. So basically what it means is that you're asking 5 YW questions, asking why, what happened, what did you eat, what happened. And a lot of people are telling me, I didn't fall, but I have a lot of pain. Why is it? Lately, a lot of people, I didn't fall, I didn't have an accident, but I fall. I have the pain on hip, etc. Or some people tell me I have a headache right in midday, or some people say right at 4 p.m. I have one chronic headache patient. Right, it hit to the 4 p.m. Her headache rises. Right around 11 a.m., 11 p.m., then it subsides. So, etc. All those time matters. Time matters according to the day. Time matters according to the season. So all those little things, because the Tibetan medicine part of observation is not just to see you, the individual cell, but also you are actually localized, or you are in a universe. So every part of your body is connected to the external change. So this is the thing what we check through the 3 medical systems, 3 diagnostic methods. So for this patient, I did the same way. And so I want to just mention what I want to say about this. For this particular patient, what I found, each doctor's side with the fingers, I put that detail. But each organ, each finger, side of the finger, they are indicated to solid organ or hollow organ. It's almost like we are programmed this way. So this is the way we are checking on patient. You ask why, there are many reasons. But on the other hand, this is where I found the heart in general for a male patient. And this is the fingers. The middle finger is my doctor's right hand, patient left hand is the spleen, etc. It indicates different things. So I did this for the patient. So all the pulse, everything, I found out this patient is a really deep thing, very fragile. It hardly ever can feel it, and even when you press hard, you can leave it finger marks there. And the patient tongue and the tongues are thick, cold, pale, etc. And the complexion is very important. This particular patient has as Erica mentioned, she gained weight after her father passed away, and she has the classical sign of pale color on her, and it's kind of penetrate out. You can see through her legs down all the waist. So also mental fogginess was one of the major things that really slows her down. And so those are the basic signs for me for this patient. When I checked the pulse, I checked her urine. I just didn't record at that time without pictures, so I didn't put here. But it was a classical sign of excess of earth and water and diminished or decreased of fire symptoms, fire being the fire element. So I started to make a treatment, diagnose with her case. So I told her you have a kidney cold condition, which underlies issue is a weak digestive fire, which you will discover more about this through Gyala later, but disturbed descending lung because she has a lot of menstrual related issues, plus also the throwing up, nausea, etc. related thing. So I have a one tongue, definitely is not for her. So all the patient, the doctor practitioner, this one doesn't look like Pagan's tongue. You will say that to me, but this is not hers. I just showed you the tongue. You look, so you will look at the crack, color, all different things. Okay, so treatment principle. What I did is, as the warm up theory. Hold on, here we go. Okay, warm up the kidney and increase the digestive heat. It will increase the kidney heat as well. Improve kidney function, and also very important thing is to reduce lung or the air elements, because that one is also accessed for her. Dry. And also because she has that cystic condition, right? When I was checking her pulse, I did not know where was that one, but I actually would felt on her kidney. Then later on, we found out it was on her kidney. Then actually, Gyala got a chance to see this patient in July, so it was one of the also uterus conditions. It's called a cystic uterus problem too. So there's many things for that. And then treatment plan, we did the integrative diet, nutrition, lifestyle, herbal remedies, as well as external warmth therapy. Of course, I didn't list the name of the medicine, but what I did is I give her all the number one is from diet. Lifestyle is no ice water, no raw food, no ice cooked raw food, because right above, one last thing, I'm stepping back. Right about the time when she came to see me, she asked me, "Doctor, can I eat raw vegetable juice?" That was her question. So at least I was able to stop her from that, because for classical pagan condition or for excess earth and water, absolutely no cold and raw food. This is the one thing. So through this presentation, we really want to, there are many people suffering from kidney conditions, but there are not many options in the other medical forms. So we're hoping through lifestyle, just changing your diet habit, we can make change from now on. Yeah.
Okay, wonderful. So we're going to continue now, and excellent comments from both Erica and Yangdron. I'm going to invite Dr. Qusar to please come up. And Dr. Qusar is here from India, and he has done a tremendous amount of work in terms of the clinical research protocols for Tibetan medicine. And he graduated from the Dharamshala Medical College, and he has been wonderful to give us his time and to come and speak with us. Speak to us and be with us. Thank you very much.
Thank you, everyone. It was a great presentation by all of you. Now I must say something regarding the background of this treatment. When we, from the Tibetan medical point of view, when we speak of a syndrome, that means in Tibetan medicine we have to include all the three principal energies together. Because when we speak of syndrome, that means we are not decided. Therefore, in Tibetan medicine, we have to consider the lung. There definitely is a lung disharmony whenever we speak of a syndrome, whether it's a polycystic ovary syndrome, or whether it's an irritable bowel syndrome, or whether it's a chronic fatigue syndrome. So therefore, as a Tibetan doctor, we have to first consider the disharmony of lung. So therefore, we have to look after the symptoms. The things that we find in Tibetan classic medical texts, that you will find a very kind of a grouping of symptoms which may be very useful in our future research studies, to put those syndromes together and then to categorize and put that into one particular type of a disorder, whether it's a lung, TIPA, or PECAN. So therefore, in the case of a polycystic ovary syndrome, we have to consider lung as the initial disharmony, and then from that whenever there is a syndrome, again all other Nyepas are involved together. So in the case of a polycystic ovary syndrome, okay, sorry. In the case of polycystic ovary syndrome, that means every other organs that are below the kidney, according to Tibetan medicine, is considered to be a pecan. So it's a phlegmatic condition in nature. That means it's a more H2O water condition, because phlegmatic condition in our system considers to be, retaining a lot of fluids in the system. So therefore, we have to consider the kidneys and all the organs below that as a cold in nature. Even if the kidney has inflammation, according to Tibetan medical approach, we have to consider that it is a cold in nature. There may be a lot of inflammation, there may be a lot of kind of acute inflammation, whether it's a hidden fever or not, we have to always consider as a cold in nature. And beginning with that cold treatment, as Yangdron treated that condition of that patient, which I remember because last time in August I was in her clinic for a short time. When we saw her in her first presentation, she has a lot of fear, because in her family condition, in her family, her father had this kind of problem and died due to that reason. She has a lot of fear, and the duty of a physician first of all to connect to the patient is to comfort the patient, because as a lung conditions, lung symptoms are predominant, we have to comfort the patient and then try to connect and then try to relate all the symptoms and then treat the condition based on the various observations, like the OPQ, which Dr. Yangdron has noted down. So, and again, with this kind of treatment, which I will present in our next session regarding constitution, we have a certain criteria to come to a conclusion to fit all those syndrome, all those different kind of non-specific or specific symptoms into a group of a disease condition based on lung, Tipa and Pecan, in whether it's an increased stage or it's a decreased stage or in a disturbed stage. So therefore, in the case of this particular patient, we have to go further, because as it is in the ovary, as it is related with the different kinds of chronic conditions, we must take into consideration, because lung can disturb in the initial stage as well as this can be in the final stage. For example, let us take a case of diabetes. According to Tibetan medicine, diabetes is a condition of a phlegmatic condition caused by phlegmatic accumulation in the system, but when the diabetes is condition is manifested, then it is the lung condition which is disturbing. So therefore, in the case of polycystic ovary syndrome, we have to always consider at the last stage of treatment that lung must be maintained in a harmonious stage. So therefore, without not taking much of time, since I think that we are lagging behind the time, I want to say that this is polycystic ovary syndrome is basically a disorder of all the three Nyepas, where it began with the lung, where we have to always consider bringing the lung in a harmony, but by taking a very serious consideration of treating Pecan disorder or the phlegmatic condition, or warming up the system, warming up the digestive function, improving the metabolic function, and improving the what you call this immune system, or raising the immune system, or not in the last stage of treatment, we have to make it sure, we have to rule it out whether there is a hidden fever or the hidden inflammation still remain in the system or not. If the hidden fever is not there anymore, that means it is a success of the treatment, and such kind of a conclusion we can come finally with the help of a urine sample, for example, like looking after the sediments, because whenever there is a hidden inflammation in the system, like for example, if the CRP protein level is higher than the normal value, that means the treatment is still not successful. Whereas if the CRP level, for example, in this case of, let us say, the polycystic ovary syndrome is under control, that means we are able to successfully root out or to treat that inflammation which is hidden under the normal condition in a very successful manner. So with this, I think my observation and my comment from Tibetan medical point of view is over. Thank you.
Comments? Yes.
How does Tibetan medicine think about autoimmune conditions?
Excellent. Okay. Do you want to address it to any panelist or to the panel in general?
Anyone who wants to
What
answer.
about autoimmune disease, and how does Tibetan medicine look at autoimmune disease and assess autoimmune diseases?
See, first of all, when we discuss about who am I,
Right.
who am I, that means according to Tibetan medicine, we are a composite of the body, mind and energy. When we speak of a body, the living body, a living body has a mind in it. Without a mind or consciousness or whatever you call it, it's not a living body. In Tibetan medicine, we call this as the Lu, which in Sanskrit is called Tan. That means it's the origin of many things. So it's origin for the formation, it's origin for the sustenance, it's origin for the disintegration. So therefore, all the mind, the body and the energy together forms the body. So therefore, when we speak of autoimmune disorder, it is all a combination of a body and mind derangement. When we are not able to make that kind of a balance of our body and mind, then we develop all kinds of autoimmune disorders. That's the Tibetan medicine explanation.
Wonderful. Excellent. Any other questions or comments? Yes, please.
You made a comment that you were treating the lung. How did you, is that just the imbalance as a result of the testing that you did or the diagnosing that you did? Did you derive from what you evaluated that the lung was low? Or was that a person that their constitution was a high lung? Or do you compare it against their constitution? Or is it just a low?
Yeah, you go through the diagnostic methods, but also you observe her case. And as doctor mentioned, she did have a lot of grief, especially ever since father passed away. Almost weight gaining, all the anxiety all started after father passed away. But of course, she had all the fears because her mom and herself are looking for alternative for her to prevent the condition, because the father was put in the dialysis. And for her, they said, you're not that severe yet, but there's nothing we can do. So you just wait, let's see what's gonna happen. So her mom and dad is really, mom was looking for anything to prevent getting worse. And then that was bring a lot of fear and increase the lung. It's a definite increase the lung. And another thing is, along with her pagan was up excess of earth and water element, so she has a more cold. So the lung is a really tricky, kind of like when there's a more existence of the cold in the body, so it also makes the colder in the body system. So she was feeling cold, frequent urination. She got all the symptoms of the lung. Yes.
Excellent. Any other questions, comments? Yes, please.
Do we know how the patient did?
Oh, yes. Yes, thank you for asking, because I had that one slide, forgot about it. I just saw her last month, good news. Actually, she's getting better. She said, one thing is I want to share with everyone is, she said, this is the only month that I have not had to have the bed ready. So she actually was doing all her daily chores daily. She didn't have to sit on the bed. Yeah, and she said she was even if her mind has become a little cloudy, never get like that fogginess, and she has motivation, keep doing things, keep thinking. Her mind is much more clear. The physically also no cramp as much. Yes.
Yes. Any other questions, comments? So I'll just end with one question that I want. It's a general question, and it's about the clinical approach and the research approach. How do we try and connect these two? Because in Western medicine, double-blind, randomized control trial is seen as the gold standard. With personalized medicine coming in, and the approach with Tibetan medicine is to personalize, how does the randomized control trial fit in? It seems like the two are in mutually exclusive in their directions. Any comments from anyone in the panel?
Basically, according to Tibetan medicine principle, we believe that there is a placebo effect, we believe that there is a nocebo effect. Since mind and body are two inseparable things in our system, everything is possible. So therefore, to do a research according to the double-blind randomized clinical trial, I did a research which I will present tomorrow based on Tibetan diet and comparing with the Western diet approach in treating obesity and cardiovascular disease, and that worked wonderful, which I will present tomorrow and I will share with you. So, but designing such kind of a research methodology, taking into consideration the Tibetan medical approach is really very difficult and very tricky, because back in Mensikang in Dharamsala, I was in the research for many years, and we have been trying many times to design a research protocol based on Tibetan medical approach, and then doing double-blind study. We did a research with the All India Medical Institute doctors in Delhi, together with Delhi, on diabetes mellitus. Of course, the research was done, but the result was not that satisfactory, because there were many flaws in our research designs as well. So slowly, perhaps we may be able to find it that way, but still doing a research based on Tibetan medical approach would be much better in the future, instead of doing just double-blind control study where there's a placebo and not a placebo and things like that would be more difficult. But in order to do that, we really have to work more together with different institutions.
I have a thought and then a question, or I'd be curious if you had any experience with this too. We're finding in Western medicine that we're having to learn more and more about how to do research using patient-reported outcomes. And it's also an area of great challenge, because it's not as clearly quantifiable. And so maybe my comment is maybe some of the things that we're learning about how to collect that kind of information will help us to extrapolate that into different types of research protocols that are accommodating of the ways that Tibetan medicine is done. And then I was going to ask, have you any experience with research protocols with patient-reported outcomes as one of the data collected?
Yeah, back in Mensikang, we did study such kind of a project, but that was not successful, because so far there were only few reporting kind of cases that were published, but that was not that much kind of a vast number of reported cases. But still, Mensikang has been trying to do that. Recently, they did a kind of a decision, and they found out that for the time being, they want to just keep on studying any kind of clinical research based on Tibetan medical approach. So the effort is going on, but still, it's a long way to go.
Excellent, thank you. Any comments? Yes, question.
I attended a Ayurvedic similar integrative approach symposium in April, and one of the presenters who has a background in chemistry and biology, and he's a researcher, and he was looking into molecules and how to approach particular illnesses through the lens of chemistry, and was getting stumped. And one of the things that he presented in terms of, much as you had said, sir, that the difficulty of coming to approach with research is looking through the lens of how we're looking. And this doctor said, I'm coming from an Aristotelian point of view, and Ayurveda is coming from one that is about holism. And that in order for research to be successful with Ayurveda, we need to investigate methods that employ a holistic approach. The ways and methods that Western medicine has been able to diagnose and use research successfully has been through a different lens, and I think this was his point, and I heard Dr. Erica mention the point of view of a philosophical point of view as being relevant, and I think in order for the future to go forward, it helps to have that philosophical point of view in place as well. So I find that very interesting today, so thank you.
Yeah, it's a very important point, this idea of reductionist approach of Western medicine, which is manifested in the research as well as in the clinical approach and treatment and so on. In contrast that with the holistic approach, which is the approach in Ayurveda or Tibetan medicine. And that approach is very different, and so the research also has to factor that in, and whether the double-blind randomized control trial actually achieves that is open, for debate. Excellent. Any other comments or any other questions? Well, yes, okay. One last question there. Yeah.
I was just wondering maybe more from an anthropological viewpoint, looking at other indigenous models of how do they measure from their own worldview what is health and healing, and how do they assess, because obviously they've done it for many thousands of years before the development of Western medicine. And I was wondering, has there ever been any investigation or comparison of those methods to see how that could then inform Tibetan medicine?
Yeah, it's a wonderful, I have a comment on that, a thought on that, but I'll invite the panel to maybe comment first. Very, very cogent thought there.
I agree. I think that's a fascinating, this tradition has been present for many thousands of years, the Tibetan medicine tradition, and understanding of what approaches worked for what conditions developed, and how did that develop. And so I think that's a great question, not just looking to one tradition, but to several, and see what we can find from them as a path.
Yeah. It's interesting because even the definition of health and disease is different in different systems. And this, in allopathic system of medicine, Western system of medicine, the sort of officially sanctioned WHO definition about absence of disease and blah, 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 which we all know, is not the definition used in various other systems of medicine. So in Ayurvedic system of medicine, the most simplistic definition, there are many definitions, but the most simplistic definition is enthusiasm to work and enthusiasm to do good for others. If you have those two things, you are healthy. And if you think about it, it captures physical, mental, spiritual, all those things are captured within those two things. So if you get up in the morning and you have enthusiasm to work, you're healthy. So on that high note, I want to thank the panel for your wonderful presentation. And I know we have run a little over time, but hopefully we'll catch up in the subsequent.